Hello everyone, welcome in first lecture in Dental Camp. My name is Rana Muhammad and I am excited to present on the topics of oral pathology, a vital field that bridges dentistry and medicine. Oral pathology focuses on the diagnosis and management of diseases affecting the oral and maxillofacial region. Today, we will explore the developmental defects of the oral and maxillofacial region. By the end of oral pathology topics, I hope to enhance your understanding of how oral pathologies can be identified and treated, ultimately improving patient outcome. We're going to talk about introduction of every diseases, clinical feature, histopathological feature, and the treatment. First, we're going to start with oral facial cleft. Development of central face begins around the end of the fourth week of human development. During the sixth and seventh week of development, the upper lip forms. During the sixth week, forms the palatal shaft. Cleft lip is a defective fusion of the medial nasal process with the maxillary process. Cleft palatal is a failure of a palatal cell to fuse, resulting in cleft palate. The causes: the maternal alcohol and smoking, the maternal consumption of corticosteroid, anticonvulsant, folic acid and riboflavin deficiency, and the excess vitamin A. The lateral facial cleft caused by lack of fusion of maxillary and mandibular process. This cleft may be unilateral or bilateral, extending from commissure toward the ear, resulting in macrostomia. Oblique facial cleft extended from the upper lip to the eye. The median cleft of the upper lip, extremely rare anomaly that results from failure of fusion medial nasal process. Clinically feature, we're gonna see it is the most common major congenital defect in the human. Cleft lip plus cleft palatal is a common in male than in female. Approximately 18% of the cases cleft lip will be unilateral, 20% will be bilateral. Cleft palatal show considerable range severity to cleft or bifid uvula. The prevalence of cleft uvula is much higher than the cleft palate. Submucosa palatal cleft is developed, the surface mucosa is intact, but a defect exists to the underlying musculature of the soft palate. Treatment: the ideal treatment should involve the multidisciplinary approach. Secondary, we're going to talk about commissural lip pits. Are a small mucosal invagination that occur at the corner of the mouth on the vermilion border, seen more often in male than in female. Clinically feature, it usually are discovered on routine examination. The pits may be unilateral or bilateral, may extend to depths of 1 to 4 mm. Some causes: a small amount of fluid may be expressed when the pit is squeezed, principally representing the salivary from minor salivary gland that drain into the depths of invagination. Histopathologically, the narrow invagination lined by stratified squamous epithelium. Treatment: because commissural lip pits are virtually always asymptomatic and unconscious, no treatment is usually necessary. Salivary secretion may be excessive or secondary infection may occur, necessitating to surgical excision of the pit. Paramedial lip pit or congenital fistula of the lower lip or congenital lip pit is a rare congenital invagination of the lower lip. They are believed to arise from persistent lateral sulci on the embryonic mandibular arch. This sulci normally disappear by the 6th week of embryonic age. Clinically feature, appear as a bilateral and symmetrical fistula on either side of the midline of the filmation of the lower limb, extending down to the depth of 1.5 cm and may express salivary secretion. Histopathologically, microscopic examination of pyramidal lipid show a tract that is aligned by stratified squamous epithelium. Treatment, if necessary, the labial beds may be excised for cosmetic reasons. Double lip is a rare oral anomaly characterized by a redundant fold of tissue on the mucosal side of the lip. Most often is congenital in nature, but it may be acquired later in life. Acquired double lip may be a component of Usher syndrome, or it may result from trauma or oral habits such as sucking on the lip. Clinically featured, the upper lip is affected much more often than in a lower lip. Occasionally, both lips are involved. With the lip at rest, the condition is usually unnoticeable, but when the patient smiles or when the lips are tendons. Histopathologically, on microscopic examination, double lip show essentially normal structure. Treatment: in mild cases of double lip, no treatment. More severe cases, simple surgical excision of the excess tissue can be performed for aesthetic purpose. Fordyce's granule is suspicious gland that occur on the oral mucosa. It normally appears in derma. Presence must be considered as a normal anatomical variation. Clinically featured, Fordyce's granule appear as a multiple yellow or yellow-white papules that are most common on the apical mucosa and the lateral portion of the filmation of the upper lip. Also may appear in the retromolar area and anterior tonsillar pillar. More common in adults than in children. Lesions are typically asymptomatic, although patient may be able to feel slightly roughness of the mucosa. Histopathological is acinar lobule can be seen immediately beneath the epithelial surface, often communicating with the surface through central duct. The suspicious cells in this lobule are polygonal in shape. Treatment: because Fordyce's granule represented as a normal anatomical variation and it's asymptomatic, no treatment is indicated. Leukoedema is a common oral mucosal condition of unknown causes. It occurs more commonly in black than in white. Clinically featured, leukoedema is characterized by diffuse gray-white or milky opalescent appearance of mucosa. The lesions do not rub off like candida. The leukoedema is typically occur bilaterally on the buccal mucosa and may extend forward into the labial mucosa. Leukoedema can be easily diagnosed clinically because the appearance greatly diminish or disappear when cheek is stretched. Histopathologically, increase in thickness of epithelium that with striking intracellular edema of the spinosal layers. The epithelial surface is frequently parakeratinized and the reticules are broad and elongated. Treatment: leukoedema is a benign condition and no treatment is required. Thank you all for your time and attention today. See you inshallah in next part of the developmental defect in oral and maxillofacial.